Okay, so now Professor Newth has entered the room so we can start. Good morning, everybody, and welcome to this session on pragmatic versus explanatory trials in pediatric and neonatal critical care. Given our tight time schedule, let's immediately start with the first presentation by Aram from the UK, giving us insights in lessons learned from the first ABC trials, I should actually say, not just study, but trials.
A trial, yes. Thank you so much. Good morning, and thank you, Martin, and thank you, Guillaume, for this invitation. And Peter, who's not here, I think, for a big thank you to Peter for inviting me to this wonderful conference. Great location. It's my first time, so I hope you're enjoying it as much as I am. I was going to talk to you for the next few minutes about First ABC, which is a set of 2 trials. It's a master protocol of 2 trials comparing high-flow nasal cannula therapy versus CPAP. So the 2 most commonly used modes of non-invasive respiratory support in critically ill children. I work in London as a pediatric intensivist at St. Mary's. I currently have funding from the NIHR, which is our UK funding body, and I do some consultancy for, so that's the disclosures. So very quickly explain to you why we did the first ABC trial. I don't think it's a big surprise. As most of us know, non-invasive respiratory support is something we use on a daily basis in our children, and the trends seem to suggest that we are using it more and more because we understand the complications of invasive mechanical ventilation. In 2 different settings, we use non-invasive respiratory support. So one is in the acutely ill child who has acute respiratory failure, and in the second setting, which is a post-extubation respiratory failure after being ventilated for a few days. And the difficulty over the last decade is that what was initially non-invasive ventilation, which was maybe CPAP and BiPAP, has evolved to become much more larger in scope in terms of being non-invasive respiratory support, and that includes high-flow nasal cannula, which has become very popular. And as you can see there, the interface between ward care and critical care has become more blurred with the use of high-flow nasal cannula. Martin is here, and Martin was the first author on this very large group of European experts looking at recommendations for everything to do with ventilation. And I've just highlighted on the left the acutely ill, acute respiratory failure patients, on the right the post-extubation patients. The questions that we didn't have any answers to in 2017, there were no randomized trials. Despite the fact that we were using these therapies regularly, constantly, we didn't have any randomized trial evidence to support whether high-flow nasal cannula was better, worse, equivalent to CPAP or any other comparable non-invasive respiratory support. So a big, big hole in the evidence base. So the first ABC trial research question was fairly simple. In critically ill children who are assessed by the clinical team who are treating them to require non-invasive respiratory supports, that's our population. And we divided that population into 2, acutely ill patients with respiratory failure and post-extubation. And I'll explain a little bit about why we chose to do this. So these are 2 different trials in 2 different populations, but packaged within a master protocol. We did this before COVID. Now, post-COVID, we would call this a platform trial. But essentially, this was a master protocol of 2 different populations. But the same therapies are being tested. So the first-line use of high-flow nasal cannula is the intervention, CPAP as the comparator. And the question was not so much a superiority question, but a non-inferiority question. And the primary outcome that we were interested in was the time to liberation from all forms of respiratory support. And the reason we chose this was because intubation or re-intubation as an outcome measure was a simple, easy to understand dichotomous outcome measure, but it didn't really have the sensitivity to pick up if patients were on prolonged time on non-invasive respiratory support, and it didn't quite capture that. So we had this composite outcome, effectively, which reflected the time that you are liberated from all forms of breathing support. The journey to completing the trials was long, so we had to start at some point, 10 years ago nearly, where we published some data on a national survey and then an international survey with colleagues across the world. And that showed that high-flow nasal cannula was used very commonly. We did some national data set analysis in the UK to show how frequently and what situations high-flow nasal cannula was being used. And we completed a pilot randomized trial, a rehearsal, effectively, in 2015-16 in 3 centers in London. And all these steps incrementally supported the progression towards the final RCTs. So the final RCT, or the definitive RCTs, were, as I said, a master protocol. They had an integrated structure, they had a shared infrastructure, and an integrated health economic evaluation. We recruited patients from pediatric critical care units across the UK, PICUs, as well as HDUs, or intermediate care units. And the target sample size was 1,200 children, but 600 in each of the RCTs. So the step-up RCT, which is the acutely ill patients, 600, and step-down post-extubation support, 600. They were independently powered to come to a conclusion so that we could make some decision about both populations effectively. The randomization was 1-to-1 to high flow or CPAP as your first-line choice. And the dose of high flow was an equivalent or about 2 liters per, that's liters, not mils, 2 liters per kilo per minute, or equivalent depending on your weight, flow rate, and 7 to 8 centimeters of pressure if you start at CPAP. So the inclusion criteria were pragmatic and rather simple and straightforward, not involving any scores or radiological measurements. Child who was admitted or accepted for admission to a critical care unit, who was not preterm, not an adult, and who the clinician thought needed non-invasive respiratory support. We can discuss the pros and cons of this inclusion criterion later. But essentially, if you had an acute illness, you went into the step-up RCT, and if you had post-extubation, you went into the step-down RCT. I won't cover the exclusion criteria in a lot of detail, but the one that I just wanted to highlight to you, which has got relevance for later, is if the patient had received high flow or CPAP for up to 2 hours before randomization, they were still allowed to be randomized. So obviously, we were concerned that it was not possible to always catch these patients before non-invasive support was started. So we had a pragmatic approach to this. And that I'll show you later on in the results, how that reflects in the results. The primary outcome, as I said earlier, was time to liberation from respiratory support, which was time that you were free of all forms of respiratory support, excluding just supplemental oxygen. So I've just shown in the first graphical table how you might start high-flow nasal cannula, you might switch to CPAP because you needed some other support. You got intubated, for example, as an escalation, then you got extubated, went on to high-flow nasal cannula, and then stayed off high-flow nasal cannula for 48 hours. The time at which you started your 48-hour period was the clock stopped ticking, effectively. So you had essentially from the time you started until the time you came off. The second patient has never really satisfied the criteria yet. So you can see they started, intubated, extubated, had 12 hours of nasal cannula oxygen, then high flow, then intubated again. So they're not satisfied the primary outcome yet. We had mortality and rate of intubation and reintubation at 48 hours as secondary outcomes, and a variety of other secondary outcomes, which we won't go into too much detail. But just looking at the acutely ill population, so the results of the step-up trial were published in the JAMA in June 2022. And just a quick run through the patient population. As you can see, the median age was under 1, so 9 to 10 months. At least 50% of the patients roughly had a comorbidity. So these are as we reflect our PQ population. Bronchiolitis was a big reason for admission to the HDU or PICU, so critical care units. About 50% of patients had bronchiolitis or a diagnosis of bronchiolitis. I showed you earlier the exclusion criterion where if you had received support, non-invasive support, for more than 2 hours before you were randomized, you were excluded. But if you had received it for less than 2 hours, you were allowed to be randomized. About 20% of patients satisfied that criterion. So they had received some non-invasive support before they were randomized. What that meant in practical terms was that if you were randomized and you were already on high-flow nasal cannula, which is the most commonly used therapy, you just continued. And if you didn't, then you would switch to CPAP if that was your randomized allocation. So in terms of physiology, these patients were reasonably sick. 2/3 of them had either moderate or severe respiratory distress, as classified by the nursing staff at the bedside. I've broken down the physiology in terms of respiratory rate, heart rate, and SF ratio there. And as you can see, when we look at it by age, because there is such a heterogeneity of age in the population, when you look at it by 90th centile, for example, about 2/3, 60%, had a respiratory rate more than the 90th centile, and about 55% had a heart rate more than the 90th centile for their age. And the SF ratio thresholds of under, say, 250, 265, that characterizes severe hypoxic respiratory failure was in about 40% of the population. So I would say this was a relatively sick population, probably not the most sickest and not the equivalent of a PARDS population. What happened when these children started on their allocated treatment? I won't go into a lot of the detail, but essentially about 1/3 of patients who started on high flow were classified as treatment failure, and about 50% of CPAP patients were classified as treatment failure. When you dig that deeper into that, you see the main reason for that is because many more patients switched from CPAP to high flow for patient discomfort, and these were predominantly older patients over the age of 1. And many patients who switched from high flow to CPAP did so because of clinical deterioration. So they looked worse and they had to be changed to CPAP. So what did we find? The primary outcome was non-inferiority hypothesis based. So essentially what we wanted to see was that there was not an unacceptably worse difference in the time to liberation between the two groups. And we found a roughly 5-hour longer time to liberation in the high flow group, but that was within our accepted or predefined margin for non-inferiority when we set up the trial, and so we accepted that high flow was non-inferior to CPAP in acutely ill patients in critical care. Intubation rate about 15% at 48 hours in either of the groups, and I won't go into a lot of the detail, but essentially when you look at the subgroup analysis, there isn't really much we can draw from these subgroup graphs that tell you that in one group of patients, high flow is better or worse than CPAP. The only one group that stands out, as you can see at the very bottom where there's a blue arrow, is the patients who were already on support at randomization. So remember, there were about 20% of the population in either of the groups, but the patients who were receiving support at randomization had a favorable tendency towards benefiting from CPAP. And if you try and understand why that is, and I won't go again into a lot of the detail, but if you compare the patients who were on respiratory support at randomization versus not, they were generally sicker. So these are patients probably couldn't wait for the randomization to happen and for somebody to come and initiate the research procedures, but they were put on support. Somebody said, can you please now come and randomize the patient? And they got randomized and they got put into the trial. So you can see 20% of them in the high flow group and in the CPAP group were in the severe respiratory disease distress category. And if you look at the proportions that satisfy the severe hypoxia criteria, about 50% versus 54% versus 40% in the high flow group. So it's overall sicker population that got randomized when they were on support. The post-extubation, which is the step-down trial, was published a couple of months before that in JAMA. So these were effectively meant to be twin papers, but because of some delays in analysis of the step-up paper, they got delayed by 2 months. But this was published in JAMA in April 22. And as expected, maybe, the population here was very different from the step-up population, as I think we would all agree we would see. The duration of prior ventilation in these patients before they were extubated was median of about 90 hours, so that's just short of 4 days. And the vast majority of patients were extubated with a plan to put them on non-invasive support. So they were randomized before extubation and put on some non-invasive respiratory support as a planned procedure. So that's the biggest group. And if you look at the physiology of these patients, it's a little messy because these are patients who are on a ventilator at the time of extubation or just prior to extubation, as well as patients who were extubated and had rescue support. So it's a little messy, but there is nothing massively abnormal that stands out from these numbers. So what happened to these patients? Just remember in the step up, the acutely ill patient category or group, we saw that about 1/3 of patients switched from high flow to CPAP and about half, 50%, switched from CPAP to high flow. The numbers here are very different. The high flow to CPAP treatment failure was about 37%, but CPAP treatment failure was about 33%. And as you can see here, the proportion that switched from CPAP to high flow much, much lower, not the 50% that we saw in the acutely ill population, only about 17% for patient discomfort. Whereas the rate of switching from high flow to CPAP for clinical deterioration was quite similar to what we saw in the step-up. So what did the primary outcome show? It showed that there was nearly 8-hour difference in the median time to liberation between the high flow and CPAP group, longer in the high flow group. And because the lower confidence limit of the hazard ratio was less than 0.75, as I've indicated in red there, which was our pre-specified limit, we concluded that high flow was not non-inferior, and I'm sorry for the double negative, in fact, probably a triple negative, that high flow was not non-inferior to CPAP following extubation, i.e. that we couldn't say that high flow was non-inferior to CPAP. What about the secondary outcomes? Intubation or re-intubation within 48 hours of extubation was about 13% in the high flow group and 11.5% in the CPAP group. One finding that took us by surprise and which is still unexplained is that there was a significant extra mortality at day 60 and day 180 in the high flow nasal cannula group. So you can see that the odds ratio of mortality at day 180, so this is 6 months after randomization, was 3 with significance, statistical significance, because the lower confidence interval doesn't cross 1. We still don't know why, and we are still trying to look at secondary analyses to try and work out what might have happened. What we do know is that these patients didn't die when they were in PICU. As you can see from that first row, the mortality in PICU was low, but it was sometime between PICU discharge and hospital discharge, so before they went home. Something obviously was happening in the hospital stay. What about the subgroups? So we have under 12 months and over 12 months as a subgroup, as we did for step-up. And that seemed to give some signal as to benefit for CPAP for the younger patients under 12 months compared to the older patients who possibly the point estimate was shifted towards the high flow group. So these are older children over 1 year old. But the other subgroups didn't really give us much clue. So just to quickly wind up and maybe reflect on some of the more general learning that I have personally taken away, and hopefully we can discuss these. So the key findings from the step-up or the acutely ill patient RCT is that high flow was non-inferior to CPAP as the first-line mode of respiratory support. Obviously, this meant that in the protocol, you could switch the patient if there was treatment failure. You could escalate the patient as we would do in real life, in practical terms. So therefore, when you get to the very distal outcome of intubation or re-intubation, any differences in efficacy get diluted by those rescue steps. So you can see that about a third of patients had treatment failure with high-flow nasal cannula, and that was mainly for clinical deterioration, 50% CPAP for discomfort. There wasn't really much of a signal in subgroups other than the group that was probably sicker at randomization, where CPAP was probably more beneficial, but all this is hypothesis generating rather than conclusive. So what's the bottom line? What do I do now? I start high flow as my first-line therapy for acutely ill patients. I think it's reasonable to do that, and then to switch to CPAP if there's no clinical improvement. And I expect that would happen in about 1 in 3 patients. That's the general overall conclusion. In the future, would we stratify whether it's high flow or CPAP as the first line based on severity? Possibly, but we don't have a trial to conclude that yet. What about step down post-extubation? We found high flow was not non-inferior to CPAP, so it was worse than CPAP. And high flow was non-inferior in all subgroups. So it wasn't like there was one group of patients that we could target high flow treatment for. And you can see the treatment failure rates there. So what do I do today? I now start CPAP as my first line treatment, which is a change in my practice. I was mixed, and I would try and make some decisions around what should be started, but probably more often than not started high flow as my first line therapy post-extubation. We've changed on our unit to start CPAP as our first line mode, and we would switch to high flow if there was discomfort that prevented progression of the therapy. And we expect that would happen in about 1 in 3 patients. So 3 key lessons to reflect. One is that this is a long but necessary journey to get to the end of 2 big RCTs, the only RCTs in non-invasive respiratory support at this scale in pediatric critical care. But the journey to that was long, involved surveys, cohort studies to understand what people were doing and what you couldn't do in your trial, a pilot trial that tried to help you to understand. Without that pilot trial, we would never have been able to design an effective, definitive trial. The second is the inclusion criteria allowed the clinician to decide when to put the patient on non-invasive support and then randomize the patient. And does that approach differ significantly from an explanatory trial where you have specific clinical criteria for entry into a trial? I would argue not really, because if you compare, and really there aren't many other trials to compare, but if you compare the acutely ill population only bronchiolytics to the Tramontane trial, the French trial that compared high flow with CPAP in moderate to severe bronchiolitis, Christophe Milesi's trial, you see that the age differences between first ABC step-up and Tramontane, they had younger patients, but the respiratory rate at randomization was very similar. So in our trial, we allowed the clinicians to determine when the patient would receive non-invasive support. In their trial, they had a set of criteria based on physiology. But actually, the patients who got in were quite similar. The SpO2, FiO2 ratio was in fact lower in the first ABC step-up trial. This is just the bronchiolitis subgroup. This is not all patients. And the heart rate was very similar at randomization. So it is possible that clinicians are using similar criteria in their minds and brains to randomize patients when they decide to put children on non-invasive support. So I don't think we had a big problem with this pragmatic approach. And finally, I think this is self-evident and possibly very easy to understand. Acutely ill children are not the same as post-extubation children. And so we should not really expect that high flow or CPAP would have the same effect in an acutely ill patient compared to a post-extubation patient. They're very different because the ages are different, and primarily that's driven by surgical procedures, cardiac surgery, for example, being very common in the step-down population. So your patient population is younger. It's 3 months rather than 10 months in the acutely ill patient population. Your SpO2 FiO2 ratio is higher, so less sick in the step-down population because a lot of planned use of non-invasive support. Sedation, much more frequent in the patients who are being extubated because they've already been on some sedation when they were intubated and ventilated, and they carry on some weaning of sedation as they are extubated. It probably means they're more compliant, weaker, and probably tolerate CPAP better. I don't know, these are hypotheses. And if you look at the reintubation rates, they are different. The acutely ill population was much higher risk for intubation than the post-extubation support patients, who were mostly planned. So is it surprising that we found different results in each of the trials? Not really. I think that's part and parcel of what we think is going on. Thank you very much, and a big thank you to, of course, a very big and large team that's made this happen, and happy to take questions. Thank you.
Thank you, Ram, for this. Thank you, Ram, for this fantastic presentation. We have time for one question.
Thanks, congrats. That's an amazing trial, so rare in our field, and so much needed. One question, maybe for the lessons, the pragmatic approach and the inclusion criteria. Do you have regrets to have included this bunch of patients with half bronchiolitis and half of a mixed population? Do you think that, I think it's reflects your practice, so it's good on that point, but maybe for the analysis, you may have to do some sub-analysis. I don't know if you've tried that.
Yeah, no, I completely accept that, we had to start somewhere in the field, and trying to get a trial in non-invasive respiratory support is challenging enough as it is, and to try and get buy-in from clinicians to recruit patients is, and to reflect real-life practice is challenging enough. So yes, I don't think we have any regrets that we followed a pragmatic approach, but I think in reality, in the future, a pragmatic approach that is tempered a little bit more with more subgroup refinement might be the way to go. But we've got a headline figure now, which we then can look at subgroups and maybe generate some hypotheses that we can pursue in future trials. That's what I think will hopefully happen.
Thank you. I think we have to move on. Thank you.
Thank you very much.
And I will now invite Professor Jani Xiong from Melbourne, Murdoch Children Research Institute, who will speak about the use of AI and machine learning for prediction in NICU.
Thanks very much, and thanks for sticking around. It's interesting, the title of the session, because I'm not talking about trials. I just want to pose a question to those in the audience. How many of you are confident that you know what the term artificial intelligence or machine learning means? I'm not going to ask for a show of hands, but I will admit that I was really very confused about this not that long ago. The concept of artificial intelligence really hit the world screen for the layperson back in the mid-1990s, when Deep Blue, the IBM supercomputer, beat the world chess champion Garry Kasparov at the time in a chess game played in real-life settings. And I think that really hit the world that there was a lot of potential for computers to aid us in what we were doing, and certainly in medicine as well. But really, it didn't start in the mid-1990s. It all started in Dartmouth in 1956, where there was a very famous conference where a lot of the founding fathers, they are fathers, you can see they're all men here, and a reflection of the time of artificial intelligence. They all got together in a workshop and discussed the concepts and came up with some very, very key concepts that really underpin our understanding of artificial intelligence today. So what is artificial intelligence? So John McCarthy is really sort of acknowledged as one of the leaders and founding fathers of AI. And these quotes are lifted from his very interesting website that you see there. And for those of you who'd like some interesting bedtime reading, I would direct you to that website because it is very interesting historically. He calls it the science of engineering of making intelligent machines. So machines that are intelligent, that can learn. A concept that was perhaps very revolutionary at the time. He also calls intelligence as the computational part of the ability to achieve goals in the world. And each word in that phrase actually carries a very deep meaning to it, but once again implies that you can teach a machine to learn and learn from patterns to help enhance what you do. So what is the difference between artificial intelligence and machine learning? Well, machine learning is one of the subgroups within AI, and it's a data-driven approach to artificial intelligence. And this is where it encompasses the field where computers can learn from experience and exposure to data, and it's actually co-developed with modern statistics. So if you work in a center where the AI and machine learning people aren't talking to the biostatistician, something is very wrong there, because this is supposed to be a field where both work in concert, certainly in medical research, to give you the best outcomes. I am not a computer scientist, and neither am I an engineering person, but I am a clinician researcher who works very closely with AI experts. So I'm going to talk about this from the perspective of a clinician and a researcher. What are the principles that we need to know and to think about, reflect upon, so that we can use this potentially powerful technology to enhance our work? So I'll start by talking a bit about machine learning principles, and then the translation to clinical decision support systems and what's involved in the development and the challenges. I'm going to really hone in on prediction models because that is something that we are all very, very interested in, and you've heard a lot about that in this meeting. And then just very briefly about the current applications of AI and machine learning in neonatal medicine. So machine learning. Now, the next few slides are courtesy from Dr. Kishore Nandakishore, and he is my close collaborator at the University of Melbourne Department of Electrical Engineering. And he has this beautiful, very simple concept to understand machine learning. So what is machine learning? There is this black box. You see the algorithm there. And that's where you have your very clever computer scientists and engineers to develop those algorithms. But if you think about your data, let's think about it in terms of fruit. You've got apples, you've got strawberries, you've got pears, and they're all mixed in this big basket. But as humans do, we like to sort them out. We like the basket for apples and the basket for strawberries and the basket for pears. Now, being a human, we do that naturally. This is what they look like, this is what they look like, and this is what they look like. But we can also teach a computer to do this. So we design a machine learning algorithm that can identify the fruits. So we teach and machine learning has two main arms. There's supervised learning and unsupervised learning. And supervised learning is when you teach the computer, this is the input, and this is the desired outcome. And the algorithm does it over and over and over and over again, and hopefully you get a perfect or near perfect model in the end. But you need input and output pairs. So you need to know your predictors and your outcomes, just for a clinical example. But then there's this concept of unsupervised learning, which is very, very exciting. And it's where the machine learning algorithm isn't told what the outputs are. It's just given a whole lot of inputs. And this sort of ML looks at pattern recognitions. And certainly for the respiratory physiologists and the intensivists out there, all that wonderful hours and millions of hours of monitoring data, well, there is the potential there for the computer to learn these patterns, and whether these patterns mean anything or not, well, it's up to us clinicians to guide them. So very quickly, supervised machine learning, I've already talked about. It's a training set. It's for classification. So you're given all these fruits, you teach the computer, these are the desired outputs, and the computer algorithm goes through it, it's refined until you get as perfect a model as you can possibly get. And the goal is to determine or guess the value. And there's a lot of course, mathematics and computation in there, which I won't bore you with at this time on a Saturday morning. And with unsupervised learning, as I've talked about, you have your input data, but you don't tell the computer about the output. And you let it work out what patterns that might be. And of course, that's the exciting bit where you see whether or not those patterns make any sense. So patterns or groupings with unsupervised learning. So let's very quickly move to applications in neonatal care. What are the general steps that are involved if you want to design a machine learning model to help you predict an outcome to help clinical care or research? So firstly, you have to develop the model. Then you have to evaluate your model. And then you go through this feedback loop to refine that model before you can deploy it real time. There is this lovely review in the Seminars of Fetal and Neonatal Medicine written by Jeong et al., and I would certainly direct you to that article. It explains this beautifully. However, each step, there are major challenges, which I have summarized here. And I will go through them very briefly, just highlighting the important aspects. And when you read articles that describe machine learning models for prediction, just keep some of these challenges in mind. So let's first talk about model development. A lot of the challenges come from insufficient data for training, small data sets, small n numbers, and yet you are creating this framework. Sometimes a cohort data has been impractical, and I'll give you an example in a second. There are, of course, confounding factors, data linkage, and this ever great challenge that we have from missing data. So let's look at that in turn. Many studies, as I say, cite limited data, insufficient data for creating each model. Many models that are published in the literature have not been validated with external data sets. They are often validated within internal subsets of the actual development. It is possible, but it is not ideal. You may have impractical cohort inclusion criteria, so you pick your most perfect cohort with very, very restricted inclusion criterion. And this may give you a beautiful model with a very high area under the curve. But in real-life settings, and as we've heard from Ram, pragmatism is very important in clinical medicine. This model may not be relevant at all when you apply it in real life. And finally, the concept of missingness, data leakage, and how predictors sometimes leak into outcomes. And the best example for this is if you use antibiotic use as a predictor of sepsis, there is leakage there. So, when you look at a model development paper, you have to ask yourself, is there broad applicability? And that's one of the biggest challenges for model development using machine learning. So now you've got your model. You're ready to roll it out. Let's evaluate the model. You really need to decide what metric criterion you're going to use. And this is where a dialogue between the model developers and clinicians are paramount. Are you going to rely more on the positive predictive value, or sensitivity, or specificity, and other targets? It really depends on the clinical question. And then, of course, there's the model interpretability and transparency, this black box. What does it mean? Can we work out what's gone into the black box and what the output truly means? And I'll show you in the next slide, there are some methods that are used, not perfect, but useful for us to understand. And finally, the clinician burden. With every model that is produced, it requires clinicians' input in evaluating the model, and for many busy clinicians out there, this is the last thing they need to add to their to-do list at 5 o'clock in the evening. You also need a dedicated team of clinician researchers who really truly believe in the potential of AI. There are a lot of skeptics out there. I wouldn't exactly say that this is the next silver bullet, but I think if you understand the challenges and the potential, it can potentially enhance what we do. This is SHAP, the Shapley Additive Explanations, and it's one of the charts that are produced in machine learning model development and evaluation to help you interpret the model. And basically what you see there, this is taken from a pediatric surgical model. You see all the different predictors that they've chucked into the model. And what they then produce is how much of these individual factors have contributed to the model. So, and using a metric called an impact factor. So the next step, you've got your model, you've evaluated your model, you're ready to deploy your model. So here we go. You need to identify the suitable setting. So you need proper human resources to back that up. You also do need to build the clinician's trust. Now, most of AI prediction models, I think the ultimate goal is to be able to either roll it out for research or roll it out for clinicians' use. But if you've got skeptic clinicians, the tool will just sit there looking pretty and never ever contributing to the betterment of clinical care. And there's this concept called out-of-sample errors, which I will show you in the next slide. One of the famous predictors that we know in neonatal prediction, I'll talk about the BPD prediction model produced by the NICHD. Based on a very large American sample, a lot of resources into it, validated in the American population. But I certainly know when we try it in our local Australian population, the predictability is not good. And I think it just reflects a different population, a different set of risk factors, a different set of confounders that cannot be taken into account in every model you build. So that's an example of an out-of-sample error. And you can see here in an example where in B, they've created the model, they've developed the model, they've tested the model in 2 different settings in the US. But what they have found is that there are errors. And so what you do then need to do for your own population, if you do have the resources, is to adapt the framework to your population so that you minimize these out-of-sample errors. So generalizability is a big challenge in models. So finally, I want to talk about current applications in neonatal medicine. That's a long list. I'm not going to talk about them all. I'm just really going to concentrate on prediction of mortality and morbidity. So there have been several reviews published in the literature of late. So this is one by the Dutch group, where they looked at machine learning prediction models of neurodevelopment. Now these are all ML models. It's a scoping review with 14 studies. And the predictors, well, some studies only had clinical predictors, many studies had MRI predictors, and some studies had both. The outcomes of interest were neurodevelopment at less than 3 years of age using the Bayley scales of infant development. The model performance was pretty good, with an area under the curve of up to 0.6, accuracy 0.86, and accuracy of up to 0.85, and an R squared of 91%. So that's very good metrics for a model. However, that review really did highlight some limitations. They only had a single literature source. Many of the samples were small and based on less than 100 participants, and the MRI predictors were the only ones that were looked at in those models for many of the studies. So there's still more work to go, but there's promise. And this is a respiratory conference, so we must talk about BPD. So the NICHD BPD outcome estimator, as I said, was developed in 2011 and most recently updated in 2022 with the definition as per the Jensen criterion. You'll see it, they did go through a very, very long process with multinomial regression models and looked at the probability of death of BPD at several time points. They also had internal validation, but not a lot of external validation. So Romjan in the Journal of Paediatrics earlier this year did a systematic review and meta-analysis of all the prediction models. Now, these are not all machine learning models. Some of them are just linear models using regression. 65 studies. Some were developmental models and some were validation. They had a median of 6 predictors, most of them clinical indicators, and the outcome, not surprisingly, BPD or a composite outcome of death, or BPD at 36 weeks post-menstrual age. Model performance, not too bad. External validation, a little bit lower, as you would expect, but the same story with the limitations and no calibration assessment. So once again, there is promise, but you do have to interpret these models with the thought about how generalizable are they to your population. This is my last slide, you'll be relieved to know. So take-home points. Machine learning has great potential to personalize neonatal care. We're all moving towards personalized care in the clinical and research setting. So we really should be aware of what's happening, understand the challenges, but also understand the benefits. So understanding the principles of machine learning is key. It's important to collaborate with your friends in computer science and engineering. They are very, very intelligent people, I have to say. But interpretation is key, and that's where the clinician and the researcher comes in. And I just really want to highlight the importance of generalizability to local conditions when you think about implementation. So I thank you for your attention. I'm happy to take questions.
Thank you very much for this beautiful presentation. There's a question.
Thanks very much, Neil Patel from Glasgow. Jeannie, thank you so much. That was just a fantastic presentation and really put out in a simple format for us the complexity of the subject. Can I ask a question? You mentioned around the challenges of quality of data. What do you believe in terms of general assessment of our current, particularly neonatal setting data, and whether the existing data that we have is useful for training models, or actually we need to go through a period of prospective data collection to improve it?
Well, being a researcher who does prospective longitudinal studies, if you start a study now, you ain't going to get any data for another 10 years. As a pragmatist, I suggest you start with whatever data you have now. And there are all these neonatal networks throughout the UK, Europe, US, a lot of the developed world does have them, and us in Australia as well. I would start with those. Have a look at the quality of the data, have a look at how good it is, what variables were collected, and I think the networks are the first place to go to. Those data will not be very clean. because they were collected for clinical purposes. However, let's not let perfection get in the way of progress. So look at the data, pick the data that you can actually use later on. So there's no point having really complex physiological data to put in when you know that in the end, when you want to roll it out to Nursery X doesn't have continuous monitoring that can spit out, the average heart rate over the first 4 hours after birth. So I think some pragmatism has to go there if you're thinking about a clinical tool. It's a bit different if you want to look at a research tool. I would start with what data you've got. Whilst you're doing that, and there are new studies that are happening, you think about how you collect data for the new studies, how you refine that collection. It's really important to actually collect very similar data so that whatever that's being developed can be validated. So what we are doing in Melbourne at the moment, so with the Victorian Infant Collaborative Study, we've had data for 40 years. We're starting to build some frameworks on that old data, But we do have outcomes and long-term outcomes. We do have new cohorts. Once we build the models, we can potentially test it on our new cohorts. We can potentially test it on our network cohorts. So I think you just have to be pragmatic. The time lag is long, and collecting data from prospective cohort studies just takes a long time. And missingness becomes an issue. Sorry, that was a long answer.
No, but we have a few minutes. That's okay. I have a question, maybe for the, on the methodological point of view, are there some solutions for the problem that I will propose? In fact, we know that there are some disparities in the care that we provide to the population, and disparities depending on the race or the social conditions, etc. And are there some ways to avoid that machine learning or AI-based system just perpetuate the disparities, in fact?
Look, not just machine learning, but any sort of, any model, even the old-fashioned linear models, when you want to look at a certain outcome and you realize how much socioeconomic class, racial differences, and nowadays, I guess, if you can get environmental data, so specifically for the lung, how that impacts on outcome. If you collect the right data, you put that into the model. So for instance, models that predict neurodevelopment, you must have a measure of socioeconomic class in there, because we do know that it has a big impact on outcome. So different countries collect socio-demographic data differently, but quintiles, top, bottom, you can dichotomize it. It's not as sensitive, but yes, you can do that. And certainly race, so in North America, well, in America, US, racial disparity is a very strong indicator of, say, neurodevelopmental outcomes. You must put that into the model. Whereas some other nations, it's perhaps not as strong. So you just need to understand your local conditions. So once again, that generalizability to your own population, very important.
Thank you very much.
Thank you for this fantastic presentation again. So, and it's now my pleasure to invite David Tingay to the stage. He doesn't need an introduction, so I will skip it for the sake of time, because for sure he's going to take us on the mesmerizing lecture to talk about big data to optimize ventilation strategies.
Thank you, Martin. Thank you for all coming on the morning. Very hard act to follow here, and I could probably delete a whole lot of slides if I had the ability to, unfortunately. It's almost the wrong order in some ways, because I'm going to try not to talk about machine learning, prediction, artificial intelligence, but I'm going to also disclose that I will probably have to delve into that, because I knew Jeannie would do a better job than me anyway. I'm going to talk about how we get the data to help people like Jeannie who can then use something with it. Just a quick disclosure, I'm not involved in this, but in my research group there is currently an IP, intellectual property claim on a predictive biomarker for BPD. So, Most people in this audience, I suspect, like me, they hear the phrase big data all the time. We like using the phrase big data. Probably none of us know what big data really is. It's just a nice thing to say. So I'm going to step right back and just say, what are some of the basics here? Big data is any data which is defined by having volume, having velocity, and having variety in its structure and its content. I would argue that in the ICU, it probably also needs to have variability, because that's a component of our work. And as Jeannie and Neil were saying, it also has to have value. There's no point having data that we don't have any purpose for using, or if we collect it, we give it to people like Jeannie and they say, well, I can't use that. Generally, there's 3 types of big data. There's structured data, which is well-defined, it's well-organised, it's in a data source that we can access and understand, and it is labelled, and in the phrase of big data people, that generally means that it has a controlled vocabulary. It's the data we really wish we had, because we understand where it came from, we understand what it is, and we understand how we can divide it. Unfortunately, most of the data we have coming out of our ICU or going into our ICU is unstructured data. So we cannot understand from an organisational perspective how it is being framed together. It often is highly heterogeneous. It's often very large and it's changing. And in many cases, it's stored without purpose, which Jeannie referred to in terms of how we use clinical data. Often in ICU, we have some degree of semi-structured data as well, but most of our data is either structured or unstructured. And that's generally a mixed data set where you may have a whole lot of heterogeneous physiological measures, for example, but you may at least have a labelling of what that patient was or where that data came from in terms of geography or time. But that's probably the most you have. Why should we think about big data in the ICU? Well, we are a really data-rich environment. We have complex, multiple sources of data that are going in and out of our daily practice. And most of that data, I would argue, is not just underutilised, it's actually wasted. And we don't even use it in any framework whatsoever. We love big data. We use it in our daily practice all the time. Also in the ICU setting, we have a data set which is changing. Our patients actually come in with a lot of data. And we have to understand that, which is Jeannie alluded to in the question time. We then allow our patients to generate a lot more data while they're in with us. And then we come along and we generate even more data, whether that's writing medical notes, which generally are probably about the worst data set you could ever find, and or making orders, or doing investigations, and then interpreting them and changing practice or not changing practice. And we already use big data in the ICU. And we use it in our clinical practice because humans interpret data. It's not just a computer that interprets data. Most of us on our rounds in our daily practice are making decisions based on multiple big changing data sources every day. We use it to make treatment evaluations. We do our own risk prediction even if we don't have a model to do it. And we are making physiological evaluations, which is where I'll focus most of my talk on. So, we also need to bear in mind many of the interventions and treatments we provide in the ICU are unproven, and the quality of the data that underpins our practice is generally quite sparse. So there's potentially an avenue here to use a different source of data to help prove or validate some of our treatments. Our patient treatment interactions are particularly complex, probably more complex than many other aspects of medicine. And ICU is inefficient. It's financially inefficient, it's data inefficient, it's time inefficient, and it's often treatment inefficient. If you look into a lot of discussions or review papers around big data in medical practice, they say big data is most likely to be useful in a population that is highly susceptible to practice variation in complex environments, which is pretty much what my ward round would be defined as by my fellows, I suspect. So I think there's a rationale for why we should be utilising or looking at big data in addition to other data sources. It's not a one or the other. But to do so, we now need to understand a little bit about what big data really is. So here are some very basic definitions, because I'm a fairly basic person. A predictor variable is information that's computed or measured to describe an element of a variable that you have available to you. So it's the feature of the data. We may be measuring PIP in every inflation in our patients in ICU. What do we want to do with that PIP? Are we interested in the highest value, the variation of the value, or the differences between patients or some other framework? And then the target is what Jeannie needs, which is an outcome that we want to use to help people develop or change practice or understand treatments better. And that may be binary or continuous. Some of the fundamentals to consider when you're looking at big data as a concept, you need to have the right data for the question you want to ask. There's no point having binary data for something that needs that has a continuous outcome, or continuous outcome for something that needs a binary data. The models that we can develop using big data will only be as good as the data we put in. So if the input data is poor, the models will be poor. And they will only be as good as we heard from Jeannie to the rules that are being applied. I think, and something that often isn't discussed enough or considered enough, is that we need to consider what acceptable error is when we look at ICU data sets. We don't want a model that has no error, because our patients and our environment doesn't have any error. So we need to think about certainty and uncertainty in our errors in our models. So what sort of big data can we use? Well, there's generally two purposes from ICU data that are described. One is around risk prediction, and I'll go over this briefly because Jeannie's covered it better than me. Risk prediction is around risk stratification, and we often then mean that we want to stratify risk to a single point in time for a certain set of outcomes. So usually we're looking at a binary set of data, and it's not something that's changing over time, and we know about those outcomes at that point in time. So it's usually practically reflecting decisions and events that are already made and known. Whilst I don't think the neonatal sepsis calculator is a way of using big data, it's in fact a fairly simple calculator, the process to generate the calculator requires big data, which we heard about from Jeannie and yesterday from Wes around that validation and so forth, which I'm not going to go into. We don't have many other accurate prediction calculators in the neonatal and paediatric ICU, but I just want to highlight a paper from Marcelo Amato's group, which came out a few years ago, where they took, and this is happening quite a lot in the ARDS literature now, we see quite a lot of re-evaluations of these large studies where they have collected very curated and standardised data sets. And Marcelo's group went and looked at the AART trial, which, as many of you know, is an ARDS trial looking at alveolar recruitment manoeuvres, and found that alveolar recruitment manoeuvres generally increased mortality. And they performed some risk stratification and phenotyping around the patients that were in that group. And you can see here the overall probability of a benefit from the ARDSNet trial approach versus ART for the whole population, but they were able to identify 3 population clusters and demonstrate that these phenotypes differed somewhat in their potential for an alveolar recruitment, or the risk from an alveolar recruitment manoeuvre. So I think this highlights how we can use big data in our ICU to help risk predict. But again, this is a data set that was already clean, curated, labelled and structured. So it's not what we have in general ICU practice. We are not as good in the NICU phrase. Jeannie spoke about BPD risk prediction, and Wes spoke in quite great detail yesterday around BPD risk prediction models. Generally, these use clinical data that's available to us. We are now seeing a multitude of smaller studies coming out that are creating BPD risk prediction models using big data sets around other sources of data, whether that's physiological data being assessed at the bedside, or as we're seeing in some of our pilot work here, using omics and plasma markers. So I'll walk you through this briefly. This is a pilot study, it's unpublished. So I've just blinded all of the actual biomarkers. These heat maps, I think we're seeing more and more at conferences. Generally, I think most of us who are clinicians look at them and then we either sort of blur out, or we try to work out what the real picture is in here. Maybe it's the space shuttle or something. These bits up here these are telling us about the different phenotypes for this axis. So here we're looking at clinical phenotypes. So we can see the different phenotypes based on BPD diagnosis and early respiratory status. Here we're seeing the different phenotypes for plasma biomarkers, and these are now grouped by the type of protein and their function. And then we have a heat map that tells us about the relationship, and you can see the babies that don't get BPD versus the babies that tend to get BPD. You can see that there's a group of proteins here which behave differently from another group of proteins here for those who don't get BPD and those that do. So they could be interrogated further to try to help if they understand this. And whilst this is just a discovery and there's no validation, there's definitely no external validation, we can see that when we pick the top 5 biomarkers here, they improve the predictability of BPD in this data set compared to just using the NICHD calculator. So this is just really to illustrate some of the potential we could be using large big data for. How we then use it, we need to go back to Jeannie's talk. What about early warning signs, which is, I think, what we in the ICU are quite interested in. So big data has been advocated as a way of us helping understand potential risk and modulating that risk. Here we're talking about data or clinical situations where the clinician doesn't yet know it's about to happen, but they may well in the future. So here we need new data, and often that data in the ICU setting needs to be continuous. And generally we start talking about physiological variables because we love measuring them and they're continuous. If we're going to consider how to use a physiological variable to predict a risk that might be happening to a patient, we need to think about what that variable needs to tell us. It may not be that we want the absolute number. It may not be that we want a summary over 1 or 2 or 3 days or 1 hour. It may be that we're more interested in the variability or variance for the question we need to answer. So it really how you use physiological data depends on what you want to know from it. We have some examples of using big data physiological sets to help try to provide risk prediction. Probably one of the most well-known one is the HERO score, which uses heart rate characteristic variability. It's an algorithm built in to their system to try to identify risk of sepsis in neonates. That's actually a good question to use this sort of data for, because in clinical practice, the markers we have for sepsis in preterm babies are often late and unreliable. So we know the horse has bolted after the horse has bolted, and therefore it would be logical, be better to provide treatment before the baby clinically presents in a way. And as a functional point of view, this uses high fidelity heart rate and then provides an algorithm to try to provide a predictability of risk. So it doesn't tell you the baby is septic, it just tells you there's a warning sign. I think another source of big data that we're already using to optimise respiratory care that uses physiological inputs is actually closed loop oxygen. And again, it's a question where big data probably fits in quite well. We know that hypoxia and hyperoxia are harmful. We know that our PaO2 in our patients is rapidly changing, and we have numerous publications that demonstrate that humans are actually fairly poor at controlling FiO2 at the resolution needed to minimise the variability in hypoxia and hyperoxia. And we're not going to be able to, due to our time commitments and the way we think, process that resolution of data. So closed loop oxygen takes continuous high fidelity, high volume, high variability data into a processor that decides what to do with it, and then it makes a treatment modification to try to standardise outcomes. And whilst we heard from Thomas yesterday, we don't have long-term outcome data from this, we see that these algorithms, when they're applied in clinical practice, at least reduce the frequency of hypoxia and hyperoxia. Whether that's a good thing or not depends, we still don't know. How do we get this data in? And to do that, we need to think about the data pathway or the pipeline. And the MIMIC project, which is an adult intensive care project from Boston, is a really nice illustration of how we should be doing this. And here you can see the MIMIC framework for their database in terms of the raw data they're taking in, the terminology, how it's then processed, and then the output data frames that are available for people to manipulate. I'm going to walk you through an example from our unit to illustrate some of the conditions and problems you need to think about when getting big data. It sounds much easier than it is. So here's an example. We were interested a number of years ago in whether volume-targeted ventilation was actually doing what the ventilator said. So we built a little box, plugged it into the back of our ventilator, collected all of the ventilator data every minute. We did so from 100 babies. We collected 7.5 million inflations from 100 babies. It's a big data set, it's highly variable. We can't really do that in clinical practice. And we were able to show that it was high, that the volume guarantee algorithms were accurate, and we could understand leak compensation a little bit from that. But it was a single source of data, and it wasn't really telling us what it meant for the patients. So we asked ourselves, is it possible to understand the relationship between endotracheal leak and volume-targeted ventilation and physiological parameters in our patients? And to that, we need to rethink how we collect our data, because now we have multiple sources. We have the patient, we have the ventilator, and we have our measure of physiological monitoring. How do we get all of that? It's there, but how do we get it? At least in our unit, we have one way that it all comes together, which is the electronic medical record, which brings all that data together in an unstructured, unlabelled, very chaotic way. And therein lies the problem, problem one. We know what we want, we know where it is, now we need to get it. And then what format do we get it in? Now, because we have an EMR system, we actually could use a commercial product which wasn't that expensive called the capsule system. All of this data is streaming like the Matrix into some big server in our hospital. And the capsule system basically plugs in your ICU into each room and steals all the monitor data at the same time and puts it into another server. So there overcame our problem of how do we get all of this data together, and allowed us to do that. And fortunately, it brings it into one language, HP7. So we know that all these different data sources are coming together in a single language form. Where are we going to put it? So now we have to ask ourselves, right, we're getting this data, it's all together, or some of it's together. We know what format it is, we know what language it is. Now where are we going to put it? So it gets put in a big server. I'm a clinician, I don't understand these things. So I go down to the basement, this IT guy goes, it's all right here. So anyway, I now know where it is. And now I have to ask myself, what am I going to do with that data? How often do I want to store it? So we decided to take it minutely rather than secondly. We wanted it in a common file. We asked the IT department, said, well, we can store it for you every 24 hours and then we'll create a new file with it. And then you have to ask, what file types are going to be in? Is it a file type that you can understand, that you can share, that you can coordinate with other file types? And how are we going to define it? So we decided the best way to define it, and here is what we were getting. Every day I get this report that tells me about all of the physiological and ventilator variables in my unit. How are we going to define it and how are we going to label it? We felt the safest way to label it was actually by physical bed space, because that's the only thing that's common and controlled. And you can't really see it, I intentionally made it small here. There are UR numbers or patient codes here, but they had to be entered by the nurse and often we found they were unreliable. Now we've got this huge data set and you have to ask yourself, how are you going to clean it? And that's a whole nother problem. And that is actually a really big problem that we have to deal with. And then we have to ask ourselves, how are we going to label it? Because labelling it by bed space isn't always the best way. That doesn't really mean anything. I can't go into the EMR and know what bed 42 was doing, and the patient may change. So we need to start thinking about a way of labelling and cleaning that allows us to use it and then allows us to link it with a data source we don't have, which is really the important one, the clinical data. Physiological big data is useless unless we can link it to a patient and understand the experience that patient had. So this is just highlighting some of the things you need to think about if you're going to do this. But we got through that and we can now start interrogating that data. So here you can see 100 infants again, about 140,000 minutes of data, just looking at the behaviour of measured endotracheal VTE versus endotracheal TULEP. You can see there's a relationship. Leak gets better, tidal volume gets worse, which is what we'd expect. We can start playing around with that data. And we could pull out the data for each patient. Here's 32 patients, and we can look at 24 hours of leak data, for example. And the take-home message here is, if you walk on your ward round at 8 o'clock in the morning and look at your baby's leak, it's probably just a random number for many of our babies. So maybe there's some value here in understanding these reports, which are now not that hard to generate. We can interrogate it some more and look at babies' leak based on oxygen requirement or the degree of oxygen impairment, because we were interested to know whether maybe endotracheal leak may have had a factor on oxygen hypoxic variability in our patients. And we can play around with that, generate reports which really show that there's no great relationship between endotracheal leak and oxygen impairment. This is a process. It's a process that shows you what is there. It is not a process that tells you what it means. And for that, we need clinical linkage and further analysis. Very finally, just some couple of slides talking about, actually, is it useful? Is it better than clinical practice? I think this is a really nice example from a group in Germany that used a number of different models to explore predictability of extubation success and compare it to clinical practice. They published a really nice data set. You could see the terminology they used for both clinical binary data and the continuous data they were collecting. They had it was small, a training data set and an internal validation. It wasn't externally validated, but they could see that using 2 of these models, they were able to improve the predictability of clinical practice a little bit compared to clinical decision making. But they then went on and did another study with a larger set of patients later. They explored more models. In fact, they explored 5 models. 2 of the models so overfitted the data it couldn't be used at all. And in using the same sort of rules and data set and using the same models, they actually found that the clinician was better. There's some reasons why that. They did also demonstrate that the models were better at predicting failure than success at extubation. Why did they find that? There's a number of reasons. Firstly, we just need to come back to basics. When I see a patient make a decision, I'm actually saying, is my decision right or wrong? A computer doesn't know what right or wrong is. It's just saying that what it's seeing is different from the last thing it may have seen, or it's the same. Computers and humans ask different questions with data. And coming back to this very famous statement, these were highly experienced clinicians. Maybe in less experienced clinicians, the outcome of the clinical data compared to the machine learning may have been different. And it may be that even if the model, the predictability is the same as clinical data, it may have efficiency outcomes elsewhere in our work. So in summary, ICU is a rich data source. It's often an underutilised data source. Big data is suited to understanding complexity, certainty and uncertainty, and I think that's really important in ICU. We need to think about uncertainty of our data and not just certainty in a population that's vulnerable and variable. It's not just about capturing everything you can capture, because that's where it all goes apart and falls apart. We need to know how we're going to transform it into important information, and that's really hard. To do that, we need to understand what we want to use it for and why. And big data is not prediction, and generally Shakespeare says much things better than me. Big data is, this is what we know, but it's not what we may be. Thank you.
Thank you, David, for this fantastic lecture. We have time for one question. For sure, there are questions from the audience. Daniela, come up to the microphone, please. And introduce yourself.
You really need me to introduce you. Okay, right. I'm Daniel De Luca from Paris, for those who do not know me. And thank you, David, for the beautiful presentation. Some comments. It's really challenging, right? I mean, it's one of the challenges we have on top of all the others. So the question is there worth to invest and try to overcome these challenges and integrate this data and finally make them useful, as you said? Because there's also a high risk of failure anyway. You know, that we invest quite a lot of time, energy, and resources, and then at the end of the day, this is not going to change our life. Or is it worth to, better invest energies and times and so on in other fields? I have no answer, just came out of my
Look,
mind.
I think there's a strong rationale to do it. And I hope I provided that a little bit. And I think Jeannie and Wes and others have talked at this meeting about why there's potential there. So I think the answer simply is yes, we should invest. Just because we might fail doesn't mean we shouldn't invest. We should invest in things that have a strong rationale, even if they fail. The way I would reframe that, Danny, is how do we go about that process of going down the journey? I would actually advocate we should go slow and think before we jump. because I suspect that what many of us have done is, oh, there's all this great data we can get, and we actually aren't thinking about how we're going to use it, get it and clean it. Things are getting better. The last slide that didn't show up here, they took it off. I do provide a list of some resources. There is now some initiatives around, there is actually a neonatal AI network in the US, and there are actually freely available curated data sets and that you can access and start playing yourself on some guidelines in some of the common programming codes to provide some framework to learn yourself in that. And we're starting to see legislative and regulatory pathways suggesting we need to look at it. So I think the answer simply is yes, we should. The question is how and how quickly, and do we make the same mistakes that we've often made in medicine before by jumping in thinking we know too much too quickly?
Thank you very much. This is very interesting, and I had a question maybe about the cleaning of the data, because this is always a question. At what time do you suggest to do the cleaning? In fact, should we keep the wrong data, the artifacts, the missing data in the database? That, in fact, that's the strategies we use because we don't want to lose this potential information, and we clean the data for a specific study, or do you want to have a cleaned database from the beginning?
I think Jeannie would want a clean database from the time of analysis, not necessarily the beginning. I think it's going to be impossible to get a clean database. I think the process of cleaning is the hardest. Is now the hardest bit. Acquiring used to be the hardest bit, and integrating now, cleaning is the hardest bit. And I don't think I have a simple answer to cleaning because it will depend on the type of data, how it's going in and how you want it. I would suggest that actually understanding what wasn't in your data after you're clean it is very important. You may not be able to use that data for your model or your application, but you need to understand the difference between what you collected and what you've used.
Thank you. Just maybe to pursue on following the question by Daniel, it's time-consuming, and in fact, when you try to do one study, you face multiple difficulties with each time you pick a variable, you find new problems. Probably everybody of us have looked at the same issues, and so my suggestion would be we should find solution to share what we've done, and because when we have cleaned the mean arterial pressure, maybe let's just make it public, and so it can be reused. I know this is what many of us do, but I think we should find ways to collaborate, not to reproduce all the time the same.
I think process. That's absolutely right. And as I said, at PAS just recently, there was a presentation from a collaborative group from University of Virginia, Beth Israeli Hospital and so forth, which have developed a collaborative neonatal approach to cleaning, somewhat cleaning, I'm not sure it's truly cleaning, but cleaning and analysing and generating reports from EPIC-related EMR data using both clinical and physiological data sets. And as I said, that's the free open source one. You don't get access to the whole data, but you get access to some of the data to try to teach and play. But I agree, it's a lot of work and you just can't do it alone. So we do need to collaborate, and we need to have a framework of standards to work with.
Can I just make a quick comment? I think very useful comments from everyone. I mean, it's exciting work, but it's very resource intensive. How do you know when to stop? How do you know if it's worthwhile going down this potentially rabbit hole? I think the ultimate first step is to define your research question. What do you want to find out from this data? Because if you've got a very well-defined research questions, it will inform which variables you want. It will inform which variables you prioritize cleaning and the outcomes. And I think you start small, and if you see a signal, you go bigger. It's not easy. I like the comment about the shared data sets, and certainly in a lot of areas, people are pulling their data. People are talking about having some core standardized ways of even collecting the data. But as I mentioned to Neil, all this takes time. Do you wait for all this data to do? Do you wait for the perfect data set? Or do you actually start with what you've got and draw some rules there?
I think you're absolutely right. If the data is bad, the result will be wrong, and you don't know whether the data is good or bad unless you have the question to ask. So you have to have the right question. I think almost in terms of collaborating large data sets together may not always be right, because the perfect data set doesn't exist, because it's so individualised. Where collaboration I think might be quite useful is in the methodological processes. So collaborating, so instead of 5 sites trying to work out how to clean and standardise EPIC data, we have a shared collaboration in terms of the learnings.
Well, we come to the end of this fantastic session thanks to 3 excellent speakers. Thank you very, very much. And thanks to the audience for engaging. You can switch on your mobile phone now and get a cup of coffee and be back at 10:45 for the next session. Thank you very much.